Welcome back to the Deep Dive. Today we're taking a scalpel to one of the most ethically challenging areas in medicine right now.
Absolutely, and it's one that's just expanding at an incredible rate.
We're talking about cosmetic interventions. This isn't just theory, is it? This is about very specific, high-stakes GMC guidance that is, well, it's absolutely crucial for anyone facing the MSRA SJT.
That's right. And look, if you go into the exam thinking the standards are the same as general practice, you are just walking straight into a trap. The GMC sets a deliberately higher ethical bar here, and you really, really need to know where that line is drawn.
Okay, let's get right into it then. Let's set a scene, a classic dilemma.
Go on.
Imagine this. You're in a private clinic. A patient comes in. They're visibly agitated, really distressed about a, frankly, very minor physical feature.
Okay, I can picture it.
They demand an immediate, high-risk, irreversible procedure. They're offering extra cash to jump the queue, and they flat out refuse to let you involve their GP.
That is the perfect storm, isn't it? You've got commercial pressure, duty of care, patient autonomy, patient safety, all clashing.
Right, and they want it now. So what do? Do you proceed because they're paying? Do you refuse outright? Or, and this is a tempting one, do you delegate that tricky risk discussion to your very experienced practice manager?
So many ways to get it wrong.
So what's the core truth? What's the one sentence that guides us out of that mess?
The core truth is this. Professional standards for cosmetic work enforce a higher ethical threshold than general medicine. That is the key.
A higher threshold.
Yes. And it favors two things above all else: a really comprehensive psychological check for vulnerability, and a strictly non-delegable duty for the doctor who is actually doing the procedure to get consent.
Non-delegable. We'll come back to that. But why does this topic matter so much right now? It feels like the GMC is really putting the brakes on here.
Well, it's because the whole sector just exploded, and with that came really serious concerns about patient safety, about exploitation. So the GMC brought in this specific guidance to stop financial incentives from corrupting a doctor's clinical judgment. And for the SJT, this area is just gold.
Why is that?
Because the highest scoring answers are always the ones that prioritize safety, that protect the vulnerable patient. And often that means you have to deliberately slow the whole process down.
Okay, let's nail down those critical differences then. You mentioned a non-delegable duty. What does that actually mean in practice?
It is the absolute core rule that sets this field apart. The GMC is crystal clear. The doctor performing or supervising the intervention must personally seek consent.
So you can't pass it off.
You cannot pass that discussion to a nurse, an assistant, anyone, no matter how skilled or experienced they are.
That's a huge distinction because in many other hospital settings, a specialist nurse can take consent. So why so rigid here?
Because the risks are different. They're not just physical. They can be psychological, they're financial, and often they're permanent. The person holding the needle or the scalpel is the only one who can truly explain the nuance of that risk. The ethical liability rests squarely with them.
And there's another specific rule about prescribing injectables, isn't there? That's another common exam trap.
Absolutely. If you are prescribing something like a toxin or a filler, you must perform a physical examination in person before you write that prescription.
So no remote prescribing.
Explicitly banned. No phone calls, no video links, no online questionnaires for prescribing these specific cosmetic medicines. It's a direct safeguard.
So it sounds like the safest doctor is just hypervigilant.
Hypervigilant about their competence and their records. You have to work strictly within the limits of what you've actually been trained to do.
Not just what you think you can do.
Exactly. And you need rock-solid patient records. Even if it's outside the NHS, you need to be able to track outcomes, report device issues. It's all about accountability.
Okay, this is where it gets really interesting for me. The practical steps. The patient is in the chair. They're demanding the procedure. We need a framework.
Okay, we can break it down into 5 mandatory actions. They build on each other.
Let's hear step 1.
Step 1 is assessment and motivation. So you take a full medical history, obviously, but the crucial bit is you have to ask them why they want it. What outcome do they actually hope for?
And why is that? Why so important?
Because it feeds directly into step 2, the appropriateness check. Is this procedure actually going to deliver what they want? You know, if they think a minor procedure will fix some deep emotional issue,
it's not appropriate.
It's not appropriate. And that leads you straight to the most important step for the SJT.
Which is?
Step 3, psychological consideration. This is an absolute ethical duty.
Tell us more. What are we looking for?
You are actively looking for vulnerabilities. You're screening for signs of body dysmorphic disorder, maybe a recent trauma, or just a pattern of repeat requests that tells you they'll never be satisfied.
And if you spot something.
If you have any concern, even a small one, you have a duty to consult with colleagues for a proper psychological assessment. You do not proceed if you suspect something serious is going on.
So even if it means losing the fee, I am professionally obliged to stop and get that assessment.
100%. Your duty to do good outweighs their autonomy if you think the procedure is likely to cause them harm. Which brings us to step 4.
The critical refusal point.
Exactly. If, after all of that, you genuinely believe this isn't going to help them or it's not going to be of overall benefit, you must not provide it.
You have to say no.
You have an ethical duty to refuse. You explain why, you tell them they can get a second opinion, but you hold your ground.
And finally, step 5.
Disclosure and reflection. You have to give them plenty of time to think. And that time has to be proportionate to how big the procedure is.
So more risk, more time.
More risk, more permanence, more time. Days, maybe risks. And your disclosure of risks has to cover everything, the physical stuff and the psychological impact if it all goes wrong.
That sequence is so helpful under pressure. Can we make it even stickier? Is there a mnemonic?
Of course. Let's use the word PSYCH. So PSYCH.
PSYCH.
Okay. It captures those 5 must-dos. So P is for personal consent.
That non-delegable duty.
Exactly. S is for safety and skills. Work within your scope.
Right.
Y is for yes or no. Be ready to say yes or no if there's no benefit. Your duty to refuse.
That's a powerful one.
C is for consult the GP. You ask for their permission and you record it if they say no. And H is for honesty and high risk. Don't trivialize the hazards.
PSYCH. I like that. What about a visual cue for that consent rule?
Just imagine a red velvet rope around the consultation chair. Only the doctor doing the procedure can cross that rope to talk about consent and risk.
Nobody else gets past the rope.
No delegation.
Perfect. Okay, let's apply it. Let's go back to our first scenario. The distressed patient, cash in hand, refusing GP contact. Using PSYCH, what's the highest scoring action?
The highest scoring action is to politely but firmly refuse the procedure right then and there.
And the framework forces that, doesn't it?
It does. You've got clear psychological concerns, so that's the S and Y. The refusal of GP contact raises the risk, that's C. And proceeding for cash would be a complete violation of your duty to put safety over commerce. You have to use the Y and say no.
Connects perfectly. Okay, let's switch gears and focus purely on the exam. How does the MSRA use these rules to trip people up?
Right, so the exam loves to test those moments where, convenience or trying to be efficient clashes with one of these mandatory duties.
So pattern 1, delegation. Let's say you've had the initial chat, and your really experienced practice manager offers to get the final consent form signed to speed things up.
What's being tested is that non-delegable duty. The best action is simple. You, the performing doctor, must do it personally.
And the trap.
The trap is thinking that delegation to a competent person is okay. It isn't. The GMC guidance is explicit. It's not a gray area.
Okay. Pattern 2, the demanding patient. They insist on a procedure, won't work well for them, but they're adamant.
This is testing your duty to refuse non-beneficial treatment. The best action is to respectfully refuse, explaining that you can't proceed if you don't believe there's a clinical benefit. Proceeding just because they want it is wrong.
Especially if there's money on the table.
Especially then.
Okay, pattern 3, marketing. Your clinic wants to run a promotion promising risk-free, natural results.
This tests professional honesty. The best action is to insist all advertising is factual, checked, and never ever trivializes risk. Claiming something is risk-free is a direct violation of regulatory codes.
Pattern 4, GP refusal. We've touched on this. The patient says no to contacting their GP, but you suspect a complex history.
The best action here is to explore why they're refusing and document it. Then you have to assess if that refusal makes it unsafe to proceed.
And the tempting but wrong actions.
1 is breaching confidentiality and calling the GP anyway. The other is just ignoring it and proceeding. Both are wrong. You have to let the refusal inform your risk assessment.
And finally, pattern 5, a young person. A 17-year-old, they have capacity, wants injections, but doesn't want their parents to know.
This tests capacity and best interests. The best action is to encourage them to involve their parents, but also to be aware of the law. In England, the Botulinum Toxin Act sets an age limit of 18 for purely cosmetic use.
Right?
And critically, if a young person with capacity refuses the intervention, you absolutely cannot perform it. Going against their wishes is a massive ethical breach.
Let's dig into some of those specific trap answers, the phrases that sound reasonable but just kill your score.
Yes. Number one is trivializing the risk.
Like saying, oh, it's just a little bit of filler, nothing major.
That scores so poorly because you have a duty to be comprehensive. You have to explain the material risks, the things that a reasonable person in the patient's position would want to know. It's the spirit of the Montgomery ruling.
Right, there's two. Financial influence.
This is allowing your own commercial interest, maybe you get a bonus for using a certain brand, to influence what you recommend. It's a fundamental breach of trust.
Trap 3. Forgetting about follow-up.
Yes, failing to give clear written info on what was done, what device was used, and crucially, who to contact out of hours if something goes wrong. Your duty of care doesn't end when they walk out the door.
And trap 4. Using promotional tactics.
Offering it as a prize or time-limited discounts that just encourage a rushed decision. The GMC guidance is very clear that you can't exploit vulnerability like that.
Okay, let's nail this down with a rapid-fire round. If X happens, you do Y.
Let's do it.
If a patient has a poor outcome and is distressed.
You initiate the duty of candor immediately. Be open, be honest, apologize, and explain the next steps.
If you prescribe injectable cosmetic medicines.
You must perform a physical examination first, no remote prescribing.
If you use an implantable device, that might get recalled.
You have to keep meticulous records so you can identify and contact every single one of those patients if a safety alert comes out.
And if a procedure is high risk or permanent.
You ensure the patient has a significant cooling off period, measured in days or weeks, that is proportionate to that risk.
Okay. After that huge deep dive, let's boil it all down. What are the 3 non-negotiable takeaways for the exam?
Number 1, the responsibility for consent in cosmetics is non-delegable. It must be done personally by the doctor performing the procedure.
Number 2.
Psychological assessment is mandatory, and you have a core professional duty to refuse any request that you believe won't provide clinical benefit.
And number 3.
All your marketing, all your financial dealings, all your risk discussions have to be transparent, honest, and must never exploit a patient's vulnerability.
It really all comes back to that central conflict, doesn't it? Safety over commerce.
It does. And the final thought to leave you with is this. In the cosmetic sector, your professional duty requires you to protect a vulnerable patient from a decision they might regret.
Even if that means losing a fee.
Especially that means losing a fee. Professionalism is choosing safety over commerce every single time.
A fantastic discussion. For more of these high-yield breakdowns and practice scenarios designed to help you navigate the MSRA, SJT, make sure you check out pastmsra.com. We'll see you on the next deep dive.